Now I call upon Dr. Prafulla Kumar MAHARANA to speak on corneal concentration and MIC of antifungals in non-healing fungal keratitis.
Thank you. Good morning, respected judges and the delegates present here. So I'll be presenting my free paper on corneal concentration and MIC of antifungals in non-healing fungal keratitis. So what is the rationale of this study? Actually, fungal keratitis is one of the cause of corneal blindness. We all know that. And we all know that the prognosis is poor compared to bacterial keratitis. So what are the factors? One important factor is poor penetration of available antifungal drugs, and we just wanted to know what are the literature available, because classically we have been taught drug doesn't penetrate that well. So you will be surprised, we just got one article published in 2016. That was also an experimental model. Again, if you go through the result of MUT1 trial, classically voriconazole is supposed to be better penetration than natamycin, but in MUT1 natamycin was better than voriconazole. So based on all these things, we planned a study where we wanted to measure the corneal concentration of drugs, because earlier study they had measured only aqueous and vitreous humor concentration, and then to validate that we wanted to compare that with the MIC 90 of the microorganism isolated. So we did this study at RP Center, AIMS New Delhi, along with our Department of Pharmacology and Microbiology, after obtaining institutional review board approval from AIMS Delhi. Now it was a prospective observational non-randomized study. The study included all cases of fungal keratitis. Those were not responding to medical therapy of natamycin plus voriconazole for 14 days, and those who were undergoing therapeutic penetrating keratoplasty. We excluded all patients who presented with perforated ulcer or impending perforation, any systemic disease that could have affected the drug penetration, and cases where the scleral or limbal involvement was there. So this is the basic flow chart. So during therapeutic keratoplasty, the host button was divided into two halves. One half was sent to pharmacology for analysis of the drug concentration. The second half was sent to microbiology for drug sensitivity or MIC90 estimation. Now LCMS is a known method, so I'm not going into the detail of the procedure. And E-test, this is what we use to know the MIC level of different organisms that we isolated here. The statistical analysis for continuous data, we use t-test. For non-contiguous, it's a non-parametric method like Mann-Whitney, and Spearman correlation analysis was done to know if any of these factors are impacting our drug penetration. So these are the baseline characteristics. Mean age was 48 years. Most of the patients were male patients. Most of the ulcer were centrally located, and most of the ulcer were moderate to severe grade. Ulcer area, mean ulcer area was 24 mm square, and infiltrate area was 35 mm square. These are the two important parameters also we evaluated. What was the duration of voriconazole and natamycin administered before the study? So the mean duration was 21 for voriconazole and 20 for natamycin, and frequency was 9 for voriconazole and 3 for natamycin. So most common organism isolated was Aspergillus flavus, which was in 42% of the cases, followed by Fusarium, Cladosporium, and other fungal species. So the intracorneal concentration that we measured was, for voriconazole it was 8.02 microgram per gram. For natamycin, it was 80 with standard deviation of 10 microgram per gram. So these are the various factors that we correlated, like age, gender, duration of treatment, frequency of treatment, time interval from last dose, ulcer area, and infiltrate area, ulcer location, and this is the result. So, but we found that frequency of treatment and grade of ulcer, they may have some impact, but rest of the factors, they were not affecting the concentration directly. This is the complete chart. If I summarize the chart, the results were like in 9.5 or almost 10% of the cases, the concentration of voriconazole achieved in the cornea was crossing MIC 90. While for natamycin, only in 33% of cases, it was crossing MIC 90. So this probably suggests why natamycin is better than voriconazole. And surprisingly, in 50% of natamycin patients, where the MIC 90 was crossing the upper limit, and that was there for voriconazole. The explanation for this could be either the organisms were not sensitive enough to the drugs that were prescribing. So 50% and 23% was that proportionate. So to conclude, LCMS can be used to measure the intracorneal concentration, and as you can see here, the drug may be crossing the MIC90, but the drug, the organism may not be sensitive enough. So if you are dealing with a case of non-healing keratitis, go ahead with antifungal susceptibility. And lastly, the limitation of this study, you know, LCMS is not a standardized method yet, and in 10% of our cases the data was outlier. MIC90 better would be microbot dilution technique. We use E-strip, however that was because of the logistical issues. Thank you so much. I'll conclude here.
All right, thank you so much.
In cases where we cannot isolate the organism, because that's quite a number, in fungal keratitis, even in good labs, it's not always we can isolate the organism. We can see only in scraping, we can see the fungal filaments.
So ma'am, in our study we included 43 patients, 31 cases were culture proven and 12 were only smear proven. So included those patients also for analysis of the drug concentration.
But MIC we can't.
MIC we measured only on those 31 patients. Okay. We couldn't do in those 12 patients.
Okay.
Thank you ma'am.